My name is John Violet and I'm a radiation oncologist, and I shall be talking today about dosimetry and radiobiology of lutetium PSMA treatments in men with prostate cancer, and also introducing a relatively new concept, that of the whole body tumour absorbed dose. As a radiation oncologist, I'm particularly interested in how an understanding of dose-response relationships can be used to optimise radiation therapy in all its various forms. This graph is taught to us as undergraduates and explains the concept that increasing tumour control is seen with increasing radiation dose, but also increasing normal tissue toxicity. In this particular scenario, it's important to point out that what we're talking about in terms of toxicity here are late normal tissue toxicity effects, these which may not occur for months or years after treatment and are generally irreversible. Of course, the amount of normal tissue toxicity that one is prepared to accept depends upon the setting in which the radiation is being given. One is very concerned about significant late normal tissue toxicity in patients being treated with curative intent, but in patients that are receiving palliative treatments, where the lifespan may only be measured in a number of months, there is less concern about using radiation that might lead to significant late normal tissue effects. I'll come back to this a little later in the talk. So, in terms of the use of radiation dosimetry, it's interesting to compare how this is used in conventional external beam radiotherapy and how this is used in radionuclide therapy. During my normal day-to-day practice as a radiation oncologist, I deliver precise doses of radiation to tumour and normal tissues, and this is dosimetry led. I determine before treating patients the dose that I want to give to the tumour and the dose that I'm prepared to accept in the surrounding tissues, and my decisions are guided by well-established dose-response relationships that have developed over many years of clinical practice. If I compare this to radionuclide therapy, here I see treatment that is largely empiric. Administration of fixed activities of radionuclide are given regardless of the biodistribution of the isotope that define the core dosimetry in individual patients. Although dosimetry may be performed prospectively to give an idea of doses to normal tissues before treatment using tracer studies, more commonly it's available only following retrospective dosimetry studies in patients undergoing multi-administration regimes. However, in general, routine radiation dosimetry is not performed, and this, combined with the complexity of the treatment, means that dose-response relationships are not so clearly established in radionuclide therapy and are therefore not available to be used to optimize therapy. There's also significant differences in the radiobiological effects of radiation, whether delivered as external beam radiotherapy or as radionuclide therapy, and this relates to the way the radiation is delivered. The biological effects of radiation are not merely a reflection of dose, they also reflect how it is given. For example, in external beam radiotherapy, there is commonly daily application of very high dose rate radiotherapy, given standard doses of radiation. The radiation is delivered to tumours in a largely homogeneous pattern and at a constant dose rate, and this is completely different to radionuclide therapy, where treatment is given intermittently, often with weeks between each of the treatments. The radiation is often given at much lower dose. The radiation is delivered at much lower dose rates, which vary over time, and the radiation delivery is markedly more heterogeneous, with some areas within tumour and normal tissue receiving much higher doses and other areas receiving much lower doses. So although the radiobiological effects of external beam radiotherapy are very well understood, extrapolating from these to the radiobiological effects of radionuclide therapy is fraught with hazards and not clearly understood, and I draw your attention to this call for arms, really, publication in terms of effort which is needed to understand the radiobiological effects of radionuclide therapy. And this table here merely summarizes the differences, many differences between the way the radiation is delivered following radionuclide therapy, and explains why tolerance doses to external beam are probably not applicable at all to those following radionuclide therapy. So, unsealed source radiation dosimetry basically includes two components. First of all, the quantification of activity in tissues over time using serial imaging, either as planar imaging or quantitative SPECT CT, and then dose convolution techniques to convert this activity into dose. And MIRD or voxelated Monte Carlo techniques are available to do this. To date, most radiation dosimetry in the field has used planar imaging because of its widespread availability, I'm sure, and MIRD. The problem is that planar imaging and MIRD both incur inherent inaccuracies in the radiation dosimetry, and perhaps even more importantly, are very time-consuming to apply, and perhaps explain the rather limited use of radiation dosimetry and radionuclide therapy, for which I'm a firm believer that routine application is the only way that we're going to establish dose-response relationships. So, planar imaging. In this image, with pictures from the front and the back, trying to determine the radiation absorbed dose in the kidneys is likely to be affected by the overlying bowel, which, as we know, also expresses PSMA. Assessing radiation dose in salivary tissues is likely to be affected by tumour overlying in front or behind in bone, which is a common site of metastases from prostate cancer. MIRD assumes standard man and standard woman. Well, the diagrams here are clearly an oversimplification of what happens in real people in terms of their anatomy and its relationship to each other. And finally, the MIRD schema has only a very limited capacity to assess dose within tumour, relying upon the spherical module, which is commonly applied to index lesions to give an idea of the radiation dose within the tumours. But what are these index lesions? Are they the hottest lesions? Are they the coldest lesions? Are they the hottest lesion plus the coldest lesion? This is obviously a simplification. Voxelized radiation dosimetry solves many of these problems and divides the body up into a series of voxels rather than a series of body organs. And although there are some simplifications for it involved in applying these techniques, it does account for heterogeneous uptake of radiation in tumours and normal tissues, and in particular relevance to this talk, allows for a much more accurate estimate of dose in tumour. So at my institution, we've been routinely using voxelated dosimetry for a number of years now, performing serial quantitative SPECT CT scans following treatment, and then using rigid and deformable registration to align these images, and then using time activity, constructing time activity curves in each voxel using a triple phase exponential clearance model. Then using Monte Carlo derived voxel dose kernels based on the decay of lutetium-177, it is possible to produce DICOM files showing dose volumes, which can then be used to draw volumes of interest on in normal tissues and tumour. So more recently, we have began creating a volume described as a mean whole body tumour volume, and this volume attempts to estimate the whole body tumour burden. We do this by applying a 5-grade threshold to the voxel dose volumes to include all areas of significant absorbed dose, and then subsequently manually removing regions of physiological uptake such as salivary tissues and kidneys. But why use this whole body tumour absorbed dose? Well, we know that symptoms and survival in cancer, although they can be related to specific local issues, largely relate to tumour burden, with death resulting when the critical mass of tumour in the body is such that the body proceeds to physiological breakdown. Reducing symptoms in patients with metastatic disease therefore is likely to reflect the ability of a given treatment to effectively reduce the tumour burden. Now, we're not necessarily talking about eradicating all tumour in the body. Nobody, as far as I'm aware, has been cured by receiving lutetium PSMA therapy, so treatment is, although highly effective, remains palliative. Index lesion dosimetry does not adequately reflect tumour heterogeneity. For example, if your two index lesions are the two tumours within your body that show very high PSMA avidity and the other tumours don't, then even though your treatment may well eradicate these two tumours, it's unlikely to make the patients live longer. And similarly, a large number of low PSMA avid tumours, again, the treatment is unlikely to eradicate all this disease. So overall, tumour burden reduction we felt should relate to the overall tumour absorbed dose. So here's just an illustration of the workflow in our voxelated technique, the three quantitative SPECT-CT scans, which are then fused for volume of interest definition. The activity decay within each of these voxels is modelled, and then the end result is, as the image on the right shows, a dose volume map on which regions of interest can be drawn, with the operator deciding which areas he wants to know or she wants to know the dose in. So commonly we would, in lutetium PSMA, draw around the kidneys, the salivary tissues, and areas of non-tumour infiltrated bone. So the study population for our dosimetry work was 30 patients being treated within a prospective clinical trial. All patients, in order to get onto the study, had to show high PSMA expression on pre-therapeutic gallium PSMA PET scan and received up to 4 cycles of therapy with a dose adjusted based upon tumour burden, weight and GFR. Dosimetric assessments were made following the first cycle of therapy. In addition to determining whole body tumour absorbed dose, we also were interested in whole body tumour volume determined on the staging gallium PSMA PET scan, and we determined this using a similar thresholding to that used in the determining whole body dosimetry, with removal of physiological areas of uptake. The particular point that we were interested in with our studies was the relationship between the screening gallium PSMA PET indices and absorbed dose and tumour response, and also the difference in absorbed dose in patients to the whole body tumour volume that received a significant PSA drop, defined as a more than 50% fall in the PSMA serum PSMA readings. 30 patients were eligible for the study. All of these patients had a very advanced disease and aggressive disease, as reflected in the very short PSA doubling times, and had received multiple lines of therapy beforehand. Now, looking at the absorbed doses from the tissues, perhaps to me as a radiation oncologist, the most important findings here are that although actually the absorbed dose in normal tissues per administered activity was relatively low, the range of differences between individual patients was huge, often an order of magnitude within normal tissues. And this to me just highlights that, fixed activities are unlikely to be optimal in terms of minimizing or controlling the dose to normal tissues, though the modelling suggests, or the dosimetry suggests, that for most patients, multiple cycles of therapy, given that the activities used in the study, are unlikely to exceed conventional normal tissue tolerances. If you compare our dosimetry to the published literature, perhaps the first point to note here is that all the other published data in this area, though it's possible that there are more recent studies, have used MIRD as opposed to using a voxelated technique, and most of them used blood sampling to determine marrow absorbed dose. But in general, our doses concur with those seen in other published studies. Our kidney doses are perhaps a little bit lower, suggesting maybe the effects of overlying bowel and the use of 2D imaging. Our doses to salivary tissues, again, somewhat lower than those reported, again, possibly reflecting artificially high absorbed dose estimates using planar imaging. Looking at the bone marrow doses, our dosimetry suggests much higher doses to the bone marrow than many of the other series, but this wasn't clinically reflected in a high incidence of cytopenias, and we suspect it relates to the method that we used to estimate a marrow absorbed dose, which was to draw regions of interest within the axial skeleton almost certainly containing occult disease, which is likely to have made the dosimetry estimate somewhat higher. In terms of tumour absorbed dose, again, there's very wide variability in absorbed dose between in bone and within lymph nodes between different patients. Somewhat less variability looking at the mean whole body absorbed dose receiving greater than 5 gray, but again, significant variability between them. Anyway, as I said at the beginning of the talk, I'm a radiation oncologist, and my interest is how do the radiation dose response relationships, what are they following treatment with lutetium PSMA, and how can we use them to optimize treatment? So this slide shows that there clearly is a correlation, not a very strong correlation, but certainly a statistically significant correlation between uptake on staging gallium PSMA PET and whole body tumour absorbed dose. Of course, this relationship would be much stronger if we hadn't already set a reasonably high cutoff value for eligibility to come onto the study. But this is a tool which we could use. To give an idea a priori which patients are likely to receive high doses to their tumour. In terms of the tumour absorbed dose, this graph shows that the index lesion dosimetry, although there is a trend, clearly doesn't relate to biochemical response in these patients. And as I said, our suspicion was that this was unlikely to be the case because knowing the dose in a few small areas of tumour, it's difficult to see how that can reflect the heterogeneity in tumour uptake that is observed on a PET-CT or a SPECT-CT scan. However, looking at whole body tumour dose, which is an attempt to encompass the dose to the global burden of tumour, clearly shows a highly statistically significant relevance. Of patients receiving a mean whole body tumour dose of less than 10 gray, virtually none of those patients had a significant PSA fall, whereas those receiving above 10 gray, a significantly larger number of those patients did have a PSA response, which was reflected in clinical improvement as well. The associations are perhaps even stronger if one looks at any PSA response and its relation to whole body tumour absorbed dose, as you can see in this graph here. So, in summary, what we know from the effects of radiation, from many years of study of the radiation biology of tissues, is that absorbed dose in tumour should be reflected in the ability of that dose to eradicate tumour. And what we have shown using our voxelated dosimetry tool is if you look at whole body tumour absorbed dose, but not index lesion dosimetry, biochemical response clearly does relate to whole body tumour absorbed dose. We also see that there's a significant correlation between the pre-therapeutic gallium PSMA PET scan and absorbed dose in tumour. These findings suggest that it should be possible to optimize lutetium PSMA patients patients receiving lutetium PSMA therapy based both upon pre-treatment imaging and post-therapy dosimetry. The goal, of course, here will be to select patients who are likely to receive a whole body tumour absorbed dose that is greater than 10 gray. Of course, this is a treatment strategy that works well in the palliative setting, where concerns maybe about late normal tissue toxicity are not such a concern. So, with that, I'd like to say thank you to my collaborators that have worked on this study, which was an investigator-initiated study sponsored by the Pete and Mac. Myself and Professor Michael Hoffman were the principal investigators on this study, but many members of the nuclear medicine team were involved in this study, as were teams of the uro-oncology unit that are involved in the selection and management of these patients during the treatment.